Hello friends, hello dear colleagues. Today our meeting is dedicated to one of the most relevant pathologies in pediatric ophthalmology, the diagnosis and management tactics of the obstruction of nasolacrimal duct. The modern standard for effective comprehensive treatment of patients using the DAVS system, which we have proposed and already discussed with you, includes the most common diseases in children. These are refractive pathologies, pathologies related to amblyopia of various origins, disorders of the oculomotor system, and pathologies of the tear drainage system, which are also very frequently encountered in children. And now, today we will dedicate our meeting specifically to the pathologies of the tear drainage system, the AcrioCare system in our DAVS system. We will tell you how we treat this pathology, what comprehensive treatment is provided, and what endoscopic techniques are available that are minimally invasive or completely non-invasive. We will also remind you about the anatomy of the tear drainage system and structure our interaction today so that we gain a complete understanding of what the tear pathways are, both in their modern representation and what can be done with contemporary treatment methods to fully restore patients as well as to recover from the unpleasant conditions that can sometimes arise due to neurogenic complications associated with interventions in the tear drainage system. Well, let's start from the very beginning with embryogenesis. The orbital part of the lacrimal gland is formed in embryos during the 8th week. The tear drainage system is formed from the 6th week of embryogenesis. The lacrimal canal opens into the nasal cavity during the 5th to 8th month of intrauterine life. It is important to understand this. When it opens up during this period, our pregnant future mothers need to be particularly cautious in this regard, just as they should be throughout the entire pregnancy. We know that tears are not produced at birth. Its main production begins in the 2nd to 3rd month of life. Puncta are oval openings, as we know, located at the apex of the lacrimal papillae on the posterior edge of the eyelids. Their average size is 0.2 to 0.3 millimeters. They are oriented backward, immersed in the lacrimal lake, and are designed to initially draw tears from the lacrimal lake into the nasolacrimal ducts. They become visible when we avert the lower or upper eyelid. The lacrimal canals begin with an ampulla. This is a short cossovertebral part of the lacrimal canal. Then the canals bend at a sharp angle and run horizontally. They then open into the lacrimal sac. The upper lacrimal canal is shorter than the lower one. The point where the canal enters the lacrimal sac is usually located behind the inner canthus of the eyelids. This is an important anatomical circumstance that in fact determines the primary pumping function of the lacrimal sac thereafter. They enter the upper part of the lacrimal sac, where these lacrimal canals either divide into puncta or a common duct, or they enter the lacrimal sac through a common duct. In the area where the common lacrimal canal enters the lacrimal sac, American researchers identify 3 anatomical structures. This is important here because it is a new aspect in anatomy, known as the Meyer sinus. This is an ampullary dilation of the common canaliculus right at the opening before it drains into the lacrimal sac. At the bottom, this fold is from the mucous membrane, which is known as the Gushka valve, and at the top, it is also the Rose-Muller valve. These valves specifically prevent the retrograde flow of tears from the lacrimal sac back through the lacrimal canals towards the tear lake in order to maintain proper tear drainage. The lacrimal sac is located in the lacrimal fossa, which is formed by the frontal process, the maxilla, and the lacrimal bone in a triangular recess within the corresponding fascial sheath. Medially, the periosteum of the lacrimal fossa, anteriorly the internal ligament of the eyelids, and posteriorly the tarso-orbital fascia. It should be added that the periosteum, approaching the lacrimal sac, splits into 2 layers, one of which passes medially between the sac and the bone, while the other passes laterally. As a result, the fascia of the lacrimal sac is formed, known as the lacrimolesi fascia, to which the upper and lower perceptal parts of the orbicularis oculi muscle and the Horner's muscle are attached. Again, during blinking, this entire structure ensures the appropriate collapse and, conversely, the subsequent expansion of the lacrimal sac. This in turn leads to a suction effect of tears from the lacrimal lake. It functions like a pump. The length of the tear sac is 10-12 minutes. The anterior wall of the sac is thin. It is precisely in this area that complications arise when treatment is delayed or when the diagnosis is incorrectly made, and consequently, numerous misdiagnoses ultimately lead to very unpleasant complications in the form of various issues. The nasolacrimal duct is a continuation of the lacrimal sac, which opens into the inferior nasal meatus. This opening is surrounded by a venous plexus with a layer of the nasal mucosa. The opening is partially closed by a fold of the mucous membrane. This is known as Hassner's valve. In 4% of newborns, the valve is not perforated, so if it does not open on its own, it is opened either through massage or artificially. It is important to remember that the tear drainage system is not just a straight hollow tube. It is a system of valves and folds resembling venous valves. This is especially important to understand and keep in mind during probing, as no forceful action should be taken and no physical effort should be applied. The probe should pass smoothly, calmly, and without tension. Prolonged inflammation of the tear drainage system can lead to the formation of adhesions, resulting in tissue becoming loose and easily perforated. Consequently, the membranous part of the nasolacrimal duct can be easily perforated during probing, leading to the formation of tear candles and very unpleasant heterogeneous complications. Well, we've already talked about the tear pump, and we can repeat it once more. Through the puncta, the upper and lower lacrimal canals, with the help of a capillary suction mechanism, the blinking movements of the orbicularis muscle compress the ampulla, shorten the canals, and expand the lacrimal sac, creating negative pressure that draws in the tear fluid. The tear sac opening the eye, muscle relaxation, the fall of the sac, positive pressure. These are all factors that push the tear fluid through the lacrimal canals into the nose. Now that we have recalled the embryogenesis anatomy of the nasolacrimal duct, let's talk about the diseases of this system. Most often, young patients suffer from diseases of the tear drainage system. Dacryocystitis associated with inflammatory conditions of the lacrimal sac is caused by congenital narrowing or obstruction of the tear drainage system, clinically manifesting initially as catarrhal inflammation, and then as purulent inflammation in the area of the lacrimal sac, known as dacryocystitis. The main cause of dacryocystitis in newborns is the obstruction of the nasolacrimal duct, due to the presence of a germinal plug of mucus and dead embryonic cells, or an embryonic rudimentary membrane that has not yet dissolved by the time of birth. An underdeveloped non-perforated Hassner's valve, which closes this entire system, may obstruct the entrance from the lacrimal duct to the nasal cavity. A cardinal sign of this disease is redness and the discharge of purulent content from the puncta. However, in cases of congenital or post-inflammatory stenosis, occlusion of the lacrimal canals, and in the context of medication treatment, this symptom may be absent. This is the highlighting of the puncta. If the puncta have closed due to inflammation, this can happen in advanced conditions, of course. Tearing as a consequence of the condition is usually detected somewhat later, as the production of tears increases and intensifies. How to observe? It is necessary to assess the tear state in a calm condition of the child. Applying pressure to the area of the lacrimal sac causes mucopurulent content to be released from the puncta. The nature of this discharge, being mucopurulent, suggests the presence of an infectious agent. Accordingly, the prescription of antibiotics leads to a temporary improvement. Later, the process of suppuration recurs. It is, of course, very important to conduct a diagnosis for conjunctivitis, which is also common in children. But this is not difficult, in fact. The obstruction of the nasolacrimal duct can be caused not only by the plugs I mentioned earlier, but it can also be due to a whole range of other anomalies. In particular, regarding the obstruction of the nasolacrimal duct, when it opens blindly, meaning it does not open, it is a dead-end canal that is not fully formed. Or when the inferior nasal concha significantly covers the opening of the nasolacrimal duct, blocking the entrance to the lacrimal canal in the nasal cavity. Such conditions often do not resolve after standard probing and require a completely different approach to treatment, which I will discuss. As a result of doctors often forcing the probing, these patients develop iatrogenic complications, fistulas, scars, and various types of perforations in the canals, and so on. Therefore, if the probing was unsuccessful, the first time you need to examine the associated canal, look at it on the X-ray, CT, and make a decision about the further treatment strategy. In this case, we immediately conduct the treatment together with the ENT specialist, and it is very effective. We manage to cure the patient on the first attempt. We will explain this further below. Clingionological examination with contrast of the nasolacrimal duct is also used to fully assess any existing abnormalities, the type of abnormalities, the location of retention, and where the obstruction is. Accordingly, this is very important for making an accurate diagnosis. In special cases, not in all. Moving on. Well, iodine lipol is used as a contrast. Now let's talk about the various treatment methods that can and should be applied for this pathology. There are different and effective options available. We have already mentioned that inadequate and untimely treatment can pose a threat. Various complications can arise, including the possibility that a prolonged genuine process may lead to the formation of an ulcer due to the infection penetrating into the conjunctival cavity and irritating the cornea of the newborn, as well as the lacrimal sac. In some cases, sometimes, phlegmons and abscesses of the peribulbar tissue may also develop in the area of the tissue as well. Well, cases of meningitis and sepsis have also been described, but this happens extremely rarely, very rarely. Often, especially in outpatient settings, a probing procedure, known to all of us, is performed without general anesthesia. We consider this to be quite incorrect because in such a condition it is rather easy to obtain iatrogenic complications. A small, incorrect movement or awkward head tilt of the child can lead to the formation of false pathways, resulting in the subsequent development of fistulas. This is a very significant and serious drawback of performing probing in newborns under local anesthesia. We conduct, or at least try to conduct, this procedure under general anesthesia at all times. Well, here, yes, it shows how false passages can form. Where can they open up? Either on the cheek, or they may open into the cavities, into the sinuses. It varies, depending on the degree of damage caused by the neurogenic factor. Here, look, this is exactly the place where the obstruction of nasolacrimal duct opens into the nasal cavity. You see, the lower nasal concha covers all of this from above. This lower nasal concha can be very closely opposed to the wall of the nose and can obstruct this entrance, more precisely, this opening. And no matter how many times we probe, there will never be any opening of the nasolacrimal duct, and there will always be absolutely definite recurrences. Therefore, it is essential here, I repeat once again, since it did not work out the first time, to immediately examine the tear drainage system endoscopically from above in appropriate stationary conditions, and to look at the nasal cavity from below, again in an endoscopic manner. Next, if necessary, the lower nasal concha should be, if necessary, in an appropriate manner retracted, and a stent should be introduced through the lower and upper puncta, securing it in the nasal cavity. After 1.5 to 2 months, the specified stent is removed, and the nasolacrimal duct is usually fully formed for life, allowing the child to recover. We perform the same operations when there is a complication from the lacrimal canals, or when there is an iatrogenic complication involving damage to the lacrimal duct, including its stenting and subsequent treatment. So we have indeed covered the etiology, embryogenesis, anatomy, and many other aspects today, as well as the methods of treatment. The most important thing from everything I have said is that you should know that today we have the opportunity to very effectively perform stenting for newborns in complex cases and complications, those cases that do not respond to conventional probing. Additionally, we can now perform probing under general anesthesia, which is significantly more beneficial for the child, as well as for the surgeon. Well, that's probably all I had to share with you today. I hope you found it useful and enjoyable. Best wishes and see you at the next meetings. Yes, and I will be very happy if you ask questions. We are ready to answer them for you now. Thank you.